Good morning, everyone. We are going to do a quick roster check to see if we have quorum. So we'll go through the roll call here. I'll go ahead and call the order at 9 a.m. and hopefully we will have a quorum.
Alyssa Michael, Brent Burgett, Brian Stevens.
I'm here. Good morning.
Good morning. Clifford Jones. Colin Stewart.
I keep I forget on one too. Dr. Stewart and Chief Burgett, if you can just let us know either in the chat or come off mute and say you're online and we can get your attendance reported, please.
Damian Johnson.
Here.
David Notrika.
I'm here.
Esther Bissonette. Forrest Taylor.
Present.
Bronco Castro Marin.
Here.
Gail Bradley.
Present.
Dark Gamer.
Present.
Herman Butler. Iman Feiserpen.
Here.
Jordan Weinberg. Nick Elk.
Present.
Zane Kelly. Dr. Kelly. Brian Southworth.
Here.
Sandy Niger. John Boker.
Here. Shelley, we can barely hear you guys in the room.
Vicki Bennett.
Present.
And I see in the chat we have several members. We with Mattel, Brent Burgett, we have got Sue down as attending. Thank you. Except 14 minutes for all right. We're going to do an audio check. I see quite a few comments and you can't hear us well. Can you hear us well now?
No.
Not really, no.
Okay. There is someone with a 602 telephone number that is off mute that sometimes affects the audio. I'm going to mute you.
It just sounds like everybody's very far away from the microphone.
I don't have a backup audio. I'll hear a backup audio.
We are going to go ahead and switch over to my computer here. So just give us a second while we turn off the audio in the room so that does not speak. Good morning. Can you hear me now?
That fixed it.
Yes,
Much better.
Okay. Thank you. We are using my computer audio, so I'm going to try to make this loud so those in the room can hear everyone in the group as well online. So thank you everyone for being here this morning. We do have a quorum. Thank you, Shelley. The attendance report is in your meeting packet. Just a reminder that if you missed 2 or more consecutive meetings, Bureau staff will be in touch with you to see if you would like to continue to serve on the committee. The meeting is being recorded, so everything said as part of this meeting is part of the permanent recording and posted to the YouTube site for ADHS. So just please keep that in mind that the recording is kept and posted publicly. We would like to welcome our new member, Dr. Colin Stewart, to the State Trauma Advisory Board as well. And also welcome back for reappointment, Vicki Bennett, who has been a longtime member of this committee too.
Thank you.
Sorry, we're just trying to get mute and echo here. We have 3 vacancies currently. We have a representative from a trauma center, representative from a statewide rehab facility, and representative from an urban advanced life support-based hospital that is not a trauma center. If you're interested in serving on the committee, please email your letter of interest and CV/resume to Shelley, and she can forward that to the director for consideration. Yes, we are going to do the presentation. Just give us 1 minute. We do need to do some of our formal tasks first, and then we'll move to our special presentation. So just kind of confirming there, we have all of that with the attendance report, roll call, all complete. Thank you. All right, we have a special presenter today regarding state traffic fatality data and strategic highway safety plan. So go ahead if you'd like to speak.
Yes, good morning. I'm trying to share my presentation. See if this is going to work out. So, oh gosh, not
We
able
did
to.
see it a minute ago.
Sorry, did you see something?
We saw it a minute ago and then it disappeared. So whatever you had done initially did seem to work.
So anything now? No?
Yes, we can
Yeah.
see that.
Okay, perfect. Hi, thank you so much for inviting me to talk to you. My name is Mazen Muradovic. I'm Arizona Department of Transportation State Safety Engineer, and oversee the traffic safety section. We deal with crash analysis and then programming and funding to implement safety projects. So I'm gonna, first of all, thank you for accommodating my time. I have to jump off at 9:30 for an executive meeting, unfortunately, but I'll try to do my best to get this done. The title of my presentation today is 2024 Arizona Strategic Highway Safety Emphasis Plan, Emphasis Area Teams. What exactly is the Strategic Highway Safety Plan? It is a policy document updated every 5 years under federal guidelines. Purpose is to develop strategies for how ADOT and its safety partners can reduce fatality and serious injuries on all Arizona roadways. This is developed in coordination with what we reference as the Active Transportation Safety Action Plan. And also, it's a safety-related document which focuses exclusively on pedestrian and bicycle safety for the state of Arizona. The update on the SHSP has been completed on October 24, and it's now available for the public on this link.
Mason,
Yes, wait.
can you put it in presentation mode? It'll just make the slide deck a little bit bigger and easier for the group to see.
Absolutely. Good point. Let me see here. Let's start from this side.
Looks like the bottom right. There we go. Excellent.
Perfect. Okay, thank you, Shay. I appreciate it. So we talked about this. As we were developing the safety plan, there was a lot of stakeholders involved in this within the state of Arizona and its different agencies, such as ADOT, DPS, ADHS, DAS, and the liquor license, as well as the Governor, Office of Highway Safety, the Intertribal Council of Arizona. We have a lot of issues we're dealing with the tribes, Federal Highway Administration, Motor Carrier, and the NHTSA. So it is no secret to everybody that we are really, as well as any other state in the nation, are having issue with crashes, and Arizona is one of them. We are trying our best to try to improve the situation and try to follow a vision and a goal, creating shared responsibilities so everyone arrive home safely, reduce life-altering traffic crashes by 20% by 2023. A goal really very, very tough, but we are doing our best. So looking at the right-hand side of the slides with regard to the statistics and the fatality, we can see that fatalities are 70% higher now than in 2010. In 2022, 1,320 people died on crashes in the Arizona highway. roadways. On 2023, number of fatality went to 2308. And then in 2024, the number of fatality was, I think there's a typo here. I think that's 1308 over here. So 1308 and then 1224. We are utilizing a system that's referred to as the safe approach system. It is a new approach and shift in how we think about safety, initiated by the federal government, aims to eliminate fatal and serious injuries for roadway users, reducing likelihood of crashes, minimizing harm caused to those involved when crashes occur. This is based on a 6 safe system principle and 5 safe system element. As you see in this schematic on the right-hand side, you can see that there are all these different safe system principle around the parameters. Things like deaths, serious injuries is unacceptable. Human makes mistakes. Humans are vulnerable. Responsibility is shared. Safety is proactive. Redundancy is crucial, and this is really a big item here. We'll talk about it. Inside the wheel, we're talking about a 5 area that we consider to be a focus area there. Road safety users, safe vehicles, safe speed, safe roads, and post crashes. I wanted to kind of concentrate a little bit about the what I refer to as the redundant safety system approach. A road safety approach that uses redundant system would combine in this particular situation, as an example, the following elements to address a dangerous curve. So you don't only do 1 or 2 things, you do a lot of stuff, and you know, you are hoping that some of this will really click in and help. In this particular situation, an example is a curve. You have signage, you have advanced technology, you know, LED signs with flashing lights that activate when vehicle approaches, especially at night. In-vehicle alert system that sends warning directly to the vehicle, and then the road design. The curve is designated with a forgiving radius and rubber strip and all those items that help increase the safety countermeasure that will help reduce crashes. We have ADOT have gone through a lot of different approaches and reach out to the public regarding the safety plan. We got a lot of public engagement, several locations as we were preparing that, and you know, there was a lot of feedback. We tried to reach to the public and tell them what we're doing, and we get some responses from them. Wanted to talk about what we refer to as the emphasis areas. And when we talked about the emphasis areas, we have actually identified those 5 location types that account for most majority fatal that have occurred in the state of Arizona. So these include intersections, lane departure. We talk about human behavior and vulnerable road users. These are the pedestrians, bicycles, and worker in the zone. These are really very much vulnerable, as the name tells, and it is subject to a lot of issues. And we unfortunately have, in the state of Arizona, is a focus state by the federal government about pedestrian bicycle state problems we have in this state. So the tribal land is another big area that we focused on. We try to do our best to help the tribes with a lot of these resources and then application that can help them reduce the crashes in their regions. So briefly talking about some of these, when you talk about human behavior, and I want you to look at this, the area on the right-hand side regarding the statistics. 71% of fatality were attributed to human behavior. Drivers aged 25 to 34 had the most fatalities and serious injuries, followed closely by ages 16 to 24. passengers ages 16 to 24 and 0 to 15 had the most fatality and serious crashes. These are the ones that are actually passenger in the car. Pedestrians aged 24 to 34 was the highest in that category. Bicycles 45 to 54 was the highest. And then impaired driving, speeding, and lack of use of helmets or seatbelts were major contributors. So all these are human behavior, things that people do and take action and creates issues and behavior. And certainly one of the biggest culprit that I feel it is very serious is the use of the cell phones, of course, especially for the younger generation and high school drivers. On the vulnerable road user emphasis area, we're seeing a lot of really concerned statistics related to that category. 25% of fatality peds and bikes, while only 4% of total crashes. So this is really quite alarming. 4% involved pedestrian and bikes, yet the fatality at 25% fatality were pedestrian and bikes. So it's quite a bit of shocking information. Ped and bike fatality have generally increased over the last 10 years. I guess people are more and more are intending to use bicycle and walk and maybe be active and be health conscious, but at the same time, there need to be a lot of accommodation to the facilities that allow them to utilize their recreational habits. Most fatal and serious injuries, crashes that involve pedestrian occur when crossing mid-block at night, and that's a big thing. So it's mostly no lighting available, and that creates a lot of problem. Besides the fact that people tend not to cross at the designated area. Those involved bikes commonly occur at intersection during the day. On the intersection emphasis areas, 35% of fatality occurred at intersection, a big number. Most intersection-related fatality and serious injury occurred in a left turn angle crashes, with most of those crashes occurring at signalized intersection. Next highest intersection crash type is others, primarily composed of crashes involving pedestrians and bicyclists. The lane departure, this is really one of the big ones too. And it tends to happen a lot on the rural area as people tend to run off the road because of the speed, distraction, other factors. Most lane departure related to fatal and serious crashes occur when drivers run off the road to the right on the roadway that is not freeway. So rural condition. Tribal lands is a big one too, and they're having a lot of radio problem, and we are doing our best to help them with a lot of resources to try to maybe improve the situation and provide funding to them to where they can apply some safety countermeasures. So fatal crashes compared to all crashes on tribal land is 4 times higher than the statewide average. So you can see the concentration happening there. Not all tribal crashes data is currently reported to ADOT. That's another big problem that we deal with, is that we are the custodian of the crash data as relates to the state highways, and local agencies can actually contribute and have an agreement with the state to provide the data. It's important for us that we collect all data available, not only state, but also others. But in the situation with the tribes, we are having a little bit of problem sharing the data with them for different obvious reasons and autonomous condition or what have you. But we're working on with them, and we're getting a little better feedback, and some of the tribes have already were able to convince their tribal leaders and commissions to try to share the data with us without having any personal information included. Really briefly, we are going through these different emphasis areas to establish some strategies We have developed 80 strategies based on range engineering, enforcement, education, emergency medical service effort. And we're working on that as we speak. Several high priority, like road safety, improve visibility for VRUs, reduce high risk in movement, keep vehicles on the lane, as well as other on the safe speed, increase automated mobile enforcement on the road. So we are really working on these. We have emphasis areas teams have started, and we were assembled, and we initially get a combined meeting starting in November 24 to address and refine the recommended strategies. Please be an advocate for implementation of SHSP strategies and join the team. Let us know if you would like to be a part of this team, and we'll be happy to help. Feel free to contact our section. My name is here. My project manager that works in my group is there. And then we will appreciate all the feedback and participation of any of the stakeholders into these emphasis area. So pretty much it, Shelly. I'm open for questions if you guys have any.
Thank you, Mason. Are there any questions in the room or online?
Close contacts be shared.
Can we share your slide deck, Mason, with the committee members?
Absolutely,
Okay.
absolutely, no problem.
Thank you. Yes. Okay, if you can please email that to Shelley, and then she'll send this out to the committee members. And then I think there's a follow-up question as well.
Okay, go ahead, please.
I'll walk over to you. Part of my exercise plan. That's okay.
So I appreciate that most of the fatalities at intersections are left turning and involving left turns. Did you cone down on the number of fatalities that involve red light running?
Those data is available, but the numbers that we were actually sharing shows the majority and the maximum, the highest group category that's were actually indicated. But those are there, and then those are to be considered. But we're just going by the highest numbers right now on that particular category.
Understood. And then it seemed, how far does the definition of bicycle go for this? What I'm getting at are these motorized bicycles and motorized scooters.
Like e-bikes and e-scooters?
Yeah, and I'm thinking that those are very contributory to, or at least I bet their death rate's higher when they do get in accidents.
That's absolutely true, and I appreciate you bringing up that point. We are having and seeing a lot of problems on the local side with regard to issues happening with the operation of these scooters, and it is a local matter, and then we can have the information for it, but we are basically making sure that the locals are aware of that. But we have heard a lot of reports being how crucial that particular category is, and we're having a lot of young population affected by that, and I wonder if it's a policy thing with regard to the different jurisdiction as far as are they allowed, where can they allow them to use it. But to basically respond to that question, we're seeing a lot of issues for sure, and especially on that side.
To that point, we are trying to collect that data a little bit more specifically, both from EMS as well as from the trauma centers. One of the things that we recognize is that data wasn't necessarily being collected, but we've seen an uptick in those incidents across the state. So there is now the ability, and at the national level, EMS is really trying to gather that data, and then the trauma centers are as well. So I think we should start to see some better data collection in that regards. We've got another question in the room here. That's okay.
Thank you. I'm Harry Wilcoxon. I'm the state traffic engineer. I work at Mazen. And I actually wanted to make a couple of comments. First of all, red light running, we do check it periodically. The definition of what makes a red light a red light is more difficult than you may think. A lot of times what we get with crashes are people pushing a left. A lot of our red light runnings actually started out as left turn crashes after the yellow cycle started. But it is something we can follow up and provide more information with you. It is a problem.
I'm just thinking that there's red light and probably the valid support those.
Again, I should say again, I support them as an individual, as a private citizen. I know that they work, and I know that they provide a law enforcement tool that prevents law enforcement from having to risk their lives. That said, I'm also an ADOT employee, and I take no stand on it. Personally, I like them. Anyway. The other thing that I wanted to actually specifically mention, and the reason I'm here, was about the e-bike question. I just want to make sure we do track e-bike crashes when they involve a motor vehicle. Now, they're either coded as a bicycle or as a pedestrian conveyance, so the data is a little murky, but the important thing there is when they are struck by or strike a vehicle. There's a vast amount of information that is not being tracked by our data. That is people riding an e-bike and crashing into a parked car, crashing into a fixed object, falling off the bike. And we think that that is a heavy, that creates a heavy number of unreported, or at least uncategorized, uncollected, not sure what the categorization of would be, of injury data. So we'd like to expand that, and I'm here to offer our services, but we'd like to see just exactly how the extent of the problem. But it is an issue, and it's a concern for both the cities, the state, and regular citizens. So,
Thank you. Yes, and I think that is something we've definitely seen from our last State Trauma Advisory Board meeting in September. I know Vatzel and her team have started to pull some of that data to collect that, because many of those incidents do not involve another vehicle, but we do have quite a bit of that data. So our EMS data, we have over 1 million records per year that comes into our data system. So we have a very high volume on the EMS side, and then all of the trauma center volume comes to us as well. So between those two data sets, we really have access to a huge amount of information. And I do think that gives us the opportunity. That is our plug to our EMS partners to say, we can't collect that from EMS unless you document that. So really trying to get your personnel to document that in an area where we can track that data, because otherwise we don't have a way to know necessarily that was related to those kind of micro vehicles. Damien, I see your hand up as well.
Yeah, I have a question. You said the definition of red light running, where is that definition? That's problematic. Or not
The
clear.
definition is in state law, I believe, but it's more a question of, most police officers know what red light running is. It's more of a question of when the violation takes place in the light cycle, and whether or not it is indicated as a red light violation. That's really what we're talking about.
I do work actually as long as I'm trying to figure out how to better define that in statute.
We have not specifically. We notice it. We see it in our data, but we haven't really tried to clarify it in the sense that we don't have a great way to measure it. Most of the violations we're talking about, especially the left turn violations, technically occur when the vehicle is queued up to make that left turn, and they hesitate or they push the wall. So it is they're entering the intersection or in the intersection when the red light or when the light turns red. And the question is, when do you start calling that a red light violation?
And then Mazen, I see your hand up as well.
Yeah, I apologize. I'm gonna have to jump off. I did send out the presentation to Shelley. Please confirm that you have it. If you don't, let me know. I will try to send it again. Thank you, guys. I apologize. I have to jump off, but thank you for the opportunity. Have a good day.
Thank you as well. And we did receive the slide deck. Thank you very much.
You're welcome. Bye-bye.
So I think this is really a great opportunity. We appreciate the partnership from our traffic safety partners here in the state of looking to see of how we bring the different groups together as part of the State Trauma Advisory Board. Our goal and really the charter of this committee is to address traumatic injuries in the state of Arizona and how we can work together to address some of this injury prevention of things. Some of that comes from having data and realizing that there's lots of different data buckets and how can we bring those data sources together. So looking forward to further partnership. Yes, G-Hells.
The question is for you guys in the ADOT. Are you guys talking about legislation? House
Yep.
Bill 2059 talks about, they're trying to de-restrict speed zones on interstates in Arizona.
Yeah, great question. For those of you not familiar with it, there's a bill that was, I'm getting a lot of steps.
I know, makes up for sitting all day.
There was a bill that was introduced in the legislature about requesting an experiment where we remove the upper speed limit of a section of state highway. ADOT is opposed to it. We spoke to the legislature. I spoke to the legislator. I know DPS has also issued an opinion on it. That said, again, speaking personally, I think it's a really bad idea for a host of reasons. However, as a state employee, if that comes to pass, we would be responsible. ADOT would be responsible for removing the speed limits and monitoring the post speed change crashing.
Is there a reason behind why legislation wants to introduce this?
My understanding is that there was, and I shouldn't say that, this was tried before in one other state, Montana. It didn't. I mean, if you look at the data one way, it crashed and went down. But we don't know and don't believe that the evaluation of the Montana data is relevant to Arizona. We also don't believe that it is one thing. But we do know that one factor that always makes things worse is speed. So I don't know more than that, other than it's being floated or it's been presented. ADOT is opposed to it, but ADOT is not able to advocate one way or the other. We're just providing our input.
Thank you.
I can just add, great point that the department's not the one technical, that is they usually with concerns all the time. So that's how the political game is. This is that you're talking about Cupper's bill, Representative Cupper, and there are a lot of reasons that this could be brought to Arizona. I think that with the political landscape that we have currently, are some stopgaps that we can work through once it makes it through if it makes it through the House and the Senate and gets up to the 9th floor. So there is some opportunity there, but it is still something that I think we should continue to have conversation with, because there's no guarantee of what the administration is going to be like next year and what that's going to look like and the political landscape. So
Thank you.
Yeah. And you're doing a great job, by the way, differentiating between personal and professional. It's a tough line you guys have to follow.
I will say that in speaking to the legislator, he's aware of our concerns. And the language of the bill does give ADOT the monitoring authority, which we have anyway, and gives our director the ability to say, this isn't working. So there are some things that he did acknowledge and write into the legislation. That said, those measures that were written into the legislation are all after the fact. We have to wait until something bad happens for decisions.
Thank you.
All right. Thank you. Great discussions. All right, we will move back to our Bureau report here. In your meeting packets that were provided, there is an update on our Bureau report. I will try to be relatively brief as we go through this. First, I want to welcome officially to this committee, new Bureau Chief, Chris Hale. So welcome, Chris. We are really excited to have him here after having the vacancy for over a year. We realize that some of our other committees have gotten to meet you, but this committee hasn't. So welcome, Chief Hale. Just a few reminders in the meeting package here. We have lost a few Bureau staff, unfortunately, so both Adam Rodriguez and Julia Vinton are no longer with the Bureau. If you have any share-related questions, Josephine Johnson or Ligia Castro are our point of contacts for that. Their information is in here. Our award cycle has opened up, so our annual EMCT of the Year Awards and Trauma Awards, those nomination forms went live. We are looking for those by mid-March as close of business for those submissions. So if you know someone who is eligible and you would like to nominate, please do so. For our state rule and regulatory updates, we have had quite a bit of questions regarding our certification process. As a reminder to your personnel, they will get a reminder emails 90, 60, and 30 days out from when they are due to expire. We have had an uptick in the past year of individuals who've let their certification lapse and have continued to work. So just please remind your personnel to keep an eye on their email for that reminder. The Trauma Center site review process that has changed. The RFP process is well. We will later on the agenda talk about the trauma registry, so I'm not going to gloss over that, but we will have quite a bit of time in that later in the agenda to speak on that topic. For our strategic plan, we do have an update to that was approved by the governor's office, and also a map for our training center programs that was requested as well. Our EMS and trauma dashboards are up to date with 2024 data. Vatsal and her team are working really hard and kind of updating the next round of data. We do appreciate all the trauma centers inputting their trauma data. We have all of the EMS data. So really, as soon as we get that trauma data, Vatsal and her team can really start working and combining that and building the State Trauma Advisory Board report. For the naloxone leave behind, a big thank you to everyone who's participating. We now have 68 agencies participating across the state, 36 urban and 32 rural. We have 4,862 EMCTs trained on this program, so we are really at a good quarter of our personnel trained, and excited that we broke the 2,500 mark of kits that have actually been scanned. So you can see just under 8,400 kits have been given out to jurisdictions doing this program, but 2,500 plus cases where the crew has actually scanned that they gave it out to someone in the community. So we are really excited about this. We did have a little kind of pause lasting, I think, 20 hours with some federal funding changes that happened last week, but we're very glad that was reinstated and we're still able to continue that program. We are looking for different opportunities to continue this long term because we do recognize the benefit for the citizens of Arizona. So thank you to everyone who has participated in that. The shared dashboard is live. Agencies who would like an initial agency specific report, those were sent out November 14th. If your agency has not gotten their share report, please reach out to us and we can tell you how to request that. As a reminder, we will only send that to an organization, so a jurisdictional email. We cannot send that to someone's personal Gmail address. We just want to make sure that if you're getting this data for your organization, that you're supposed to be getting that information. And if you have any certification or enforcement questions, we have several links on the Bureau report for that as well. So that is a very quick and rapid Bureau report. Does anyone have any questions before we move on the agenda? All right. Next, we will move to our standing committee reports. First up, Sean, do we have a TEPI report?
We do. Thank you, Dr. Bradley. So TEPI met on November 20th. Minutes were approved as presented. Dr. Bradley displayed the offload dashboard, and then Adam gave the share updates, annual report info, viewing the dashboard and agency report info, and shared slides explaining data quality reports that she shares out to agencies and how to analyze for improvement. She also shared that updated codes for e-scooters and e-bikes are now available within the pick list. Thank goodness. And then Vatsal went through the dashboard for trauma injuries. And that's it for the TEPI report. Thank you.
Thank you. Next, for education, I will do that report for Sandy as she has a conflict today. So just a few updates. A big thank you to the Education Committee for approving 2 training curriculum. One was for multiple different STR for EMT IV related topics, so blood draws and different IV topics. Big thank you to the Education Committee. That was quite a bit of work helping to complete that training curriculum. And then also for the training for children and youth with special healthcare needs. This was done in conjunction with our PACES committee, so our pediatric committee. Big thank you to both of those committee members. As we're coming up in National Registry timeframe, those curriculum are posted to our website if you're looking for any training opportunities. And we have some more training meetings coming up as well. Next, I will move to Dr. Castamarin for PMD update.
Thanks, Dr. Bradley. For PMD, we approved the minutes as they were presented, and then we had 2 important approvals for Table 1, the EMCT drug box. Those go to the Medical Direction Commission later today. As well as the second approval for that table was adding infusion pump designations to Crotalid, Immune Fab, nicardipine, nitroglycerin IV infusion, 3% saline, thrombolytic medication, and vasopressin. That will also be looked at by MDC later today. And then we had a call to the public, at which point Mr. Rick Beadle provided a demonstration for his riser specialized patient gurney. Thank you.
Thank you. Next, Heather, are you on the line for a trauma program managers workshop update?
Yes, Dr. Bradley, I am. So our next trauma program managers meeting is actually tomorrow in Chandler Regional Medical Center. We're looking forward to that meeting. We've got a lot of good information for that, and I will give you a more of an update at our next meeting once we have this meeting.
Excellent. Thank you. Next, Savannah, are you online for a PACES update? Not to put you on the spot, but I thought I saw Dr. Woolrich on here. I do see you, Rich. Excellent.
Yes, hello, thank you. If Savannah's not here, I'm happy to step in on this. We have, pardon me, let me get my notes here. So the PACES meetings did meet. We did have a quorum. We approved our minutes and we approved the updates of the Department of Education Red Book. And that has been moved forward, and it was great working with the Department of Education in regards to that. We had a series of presentations. Morgan Anderson presented on the annually released 2024 Child Fatality Report. We had a presentation on the crisis system structure in Arizona for emergency responders. That was done by Amy Devins. And Dr. Bradley, thank you for acknowledging PACE's work with the Education Committee on the prior work groups. Education Committee does now have another work group that we're going to put together. We're going to assist them with, and that's going to focus on training materials for child maltreatment. We are looking for volunteers. So I would ask anybody who's interested in joining to contact either Shelley or Savannah to be able to participate in those work groups. Julia did share access to the PEDS data and trauma dashboard, or how to access the PEDS data on the trauma dashboard. We talked about the pediatric readiness results, and that we are going to be having a 2026 survey for nationwide PEDS readiness for the emergency departments. Savannah will be reaching out to members in the future on that. And I think that summarizes our last meeting. Thank you.
Thank you very much. And big thank you actually for mentioning the child maltreatment. That actually for our trauma centers, I know many of our trauma centers do outreach and work in that regards. If there's anyone from a trauma center that would like to participate in that education committee, please reach out to Shelley or Savannah, and we can add you to that group. So it would really be nice. As we see a lot of the trainings that occur, these really do cross multiple of our state committees, and it's nice to get that participation from across the spectrum, from pre-hospital to hospital and trauma centers. So thank you for bringing that up, Dr. Woolrich. Next, we will move to our discussion and action items. First one is, can I get a motion to discuss, amend, and approve the meeting minutes from September 18th, 2025? Thank you, Dr. Gamer. Can I get a second?
Second.
Thank you, Dr. Southworth. The meeting minutes are currently being projected here. Are there any recommended amendments? Hearing none. Any opposed? Any abstentions? All those in favor say aye. All right, meeting minutes are approved. Thank you. Next, discussion item, the Trauma Registry interim red cap data entry. So I will turn that over to Carissa. I believe that you are online to cover that, Carissa.
Good morning. Yes, so we went live on Tuesday for those of you who are using the REDCap database. So there is a 2025 Q4 template for full and reduced, as well as a 2026 Q1. So your registry team should have access to those depending on if they're full or reduced data set. So if you are using the ESO or had been using the ESO registry, you can continue finishing your records through the end of this month, but then you will need to use REDCap. We sent out a user's guide, just kind of a quick get you into the system thing, and we're planning on continuing to do some more education as we kind of get in the swing of things. I'm also working with a few people to get more reports built into there for RFPs and such. So, or not RFPs, sorry, PRQ. There we go. Anyway, so if anyone has any questions or is having any access issues with REDCap, feel free to reach out to me.
Thank you, Carissa. I will open it up to any questions online or in the room. I know that the Bureau has held multiple meetings with the trauma community trying to address some of the questions, but we definitely have quite a bit of time planned on the agenda today if there are questions that people have. Yeah. I'm going to bring the computer over to you just so that I can hear you online.
And so we definitely have some concerns with REDCap over the past couple of days. The question is are we still going to be looking into an interim? This is just interim as you guys look to see where you guys would formally be going with.
Did you hear the question, Carissa?
I did not. I heard probably every other word. Sorry.
Hey, Chris, it's Wendy. From like an honor health perspective, some of our questions are this is interim, so what does the time frame look like as you guys explore other registries?
I'm not quite sure. I know, like, I just got back a week ago, but I think that we are going to kind of take it month by month and see how REDCap's functioning, how we're able to build the reports. Yeah, I'll let Nicole speak to it. Go ahead, Nicole.
Yeah, I think you were doing fine, Carissa. We don't have a timetable as of yet. I think right now we're just focused on getting this interim up and running. I think as we've mentioned, we are working with our procurement office and legal counsel on this transition. So we'll have, as soon as we have more information and timeline on any additional transition, we'll be sure to share with stakeholders right away.
This is another question here in the room.
Nicole and Carissa, is there a way, understanding that this is interim and we're not sure what the future will hold, is there a way, if we do switch to a different trauma registry program, that we can export the data that is currently being inputted into REDCap into another program? Or will that require the registrars and our teams to re-enter this data, kind of duplicating their work?
I can start and Carissa can certainly add. I can tell you whatever decisions we make, our focus is always going to be on what is less burdensome for our stakeholders. So I think if we do transition to another system, our focus would be on the ability to be able to transition that data without requiring duplication of work.
Well, I think that if REDCap's not meeting the needs, which right now it's not, just in these 2 days, there's a lot of concern with REDCap and its functionality, lack of being able to run reports, getting ready for our site visits. If an organization, a hospital organization decides to step away from REDCap and go to another registry, is the functionality going to be able to export from REDCap?
So I would add REDCap can export. I think it depends on what registry you'd be going to. But I feel like most registry platforms have the ability with just mapping to get data in there. We also have Snowflake as a tool on our end. I can't say exactly yes or no, but I think with the tools we have and where other trauma platforms are at, that shouldn't be an issue. I think we could probably work it out.
Any other questions? I don't see any other questions in the room. Any other questions online from anyone? I do see a hand up.
Hey, Dr. Bradley, this is Sean Bowker. I just want to thank Carissa and your teams for trying to work through this. I know it's a surprise for you guys, and it's a surprise certainly for all of the trauma centers that are involved in this. I do want to just say, though, that this has been shocking and nothing short of disastrous for most of the trauma registry staff and for the trauma centers in general. And I want to ask, what is the state and the procurement team looking at for the future to make sure that something like this doesn't happen again? Because this is a huge, huge cost and a huge burden for the trauma centers to bear right now.
So thank you. I appreciate the sentiment of shock, and I think, again, as mentioned before, this is certainly not the place that we intended to be nor planned to be, and appreciate and know the burden and the challenges this is on all of us. The only thing I can say as far as internally for ADHS and with our leadership and procurement, we're looking at this entire situation, and certainly will incorporate any lessons learned into our future processes.
Vicky, I see your hand up next.
Yes, I just a quick question, maybe for Nicole or Carissa. What does the grace period look like for data submission? So our next quarterly submission, April 1st, looking at compliance, and with all of these changes and our ability or inability, what does that look like on your side in terms of compliance and any grace period, and where we'll go with that?
I can let Nicole speak from a more of a rules standpoint, but I've tried my best to work with you all just because we can't see a lot of your data, or we're not getting it, it's not accurate. But you sending me screenshots of your volume and sending in your data submission form. So that has been, I think, adequate for me, because I think we can recognize that this is a hard position that everyone's in. But I can't change the rules. So, but as far as my perspective of getting the data submitted, that's what I've been working with, and that's what I'll continue to kind of ask for as we go forward and try to work out all these weird moving pieces right now. But I'll let Nicole add.
Yeah, I think we've, at this point in time, Vicky, to answer your question, I mean, it's only been 2 days, so we're not looking at anything as it relates to a specific grace period or waiver, but we'll continue to work with stakeholders and see what that looks like as far as the information that you need to provide, and ensure that we can move forward.
Thank you.
I
Any
guess-
further?
Yeah,
questions?
sorry. I guess just in short, our hope is that we won't need them, but certainly know that that is something we may need to discuss.
Any further questions or comments? All right. Moving down the agenda, I will move on to Dr. Weinberg. You will appreciate, those of you who are not in the room, Matt Shaw is doing an excellent job of injury prevention and lowering his cord every time I walk with his computer so I don't trip. So, all right, Dr. Weinberg, thank you.
Morning, everybody. Just a very brief report from the Arizona Committee on Trauma. So we are
still trying to expand our membership particularly in the number of vice chairs we have. And as a current group has decided that, every state designated trauma center from levels 1 through 3 is eligible for a single vice chair position. So far, we have representation from 6 of our level 1 states. Since the last STAB meeting in September, the state held the state COT held the annual resident paper competition on October 10th. And the first and second place winners, which were respectively Hannah Shin from the University of Arizona Tucson and Riley McGuire from Creighton Phoenix, represented the state at the Region 9 competition in San Diego in December. Fortunately, Arizona did not place to advance to the national competition in March. So hopefully next year. Speaking of that, the upcoming national meeting is in March. One of our vice chairs, Natasha Herrick, will be taking on the role as chair of the National Performance Improvement Patient Safety Committee. So we look forward to her leadership there. And at our spring meeting, our spring staff meeting, I'll be able to report back from the national meeting with the highlighted quarter and the implications, if any, for the state. And that's all I got. Thank you.
Thank you. All right, next, we realize that per our bylaws, we do actually need to have a vice chair for the committee. Just in case that I am not able to be here for a meeting, we need to have someone that is able to step in for me. Dr. Southworth very kindly was willing to step into that role, so he has accepted a nomination, but we do need to get a nomination to approve a vice chair for our staff committee. So you may formally nominate yourself, or someone may nominate you with your agreement to serve in such role.
Sure.
So.
Close now.
All right, thank you, Dr. Gamer. All right, we will take a formal vote. All those in favor of approving Dr. Southworth as vice chair for STAB? Anyone opposed? Any abstentions? All those in favor say aye.
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 Thank you. Next, I need a motion to discuss, amend, and approve forming a work group to review the bylaws. This is every 3-year process. We do like to review the bylaws to ensure that it is accurate and up to date for our needs. If I can get a motion, please. Thank you. Can I get a second? That was a first from Dr. Gamer.
A second.
Second was that, Dr. Thank you, Dr. Trika. All right. Anyone who would like to participate in the riveting meeting to review bylaws?
Now, I guess the question would be, what has to be retooled to the bylaws, specifically phase?
You could explore that at an open group meeting.
So typically we don't make significant changes. Occasionally we do. Sometimes it's things like we've clarified in terms of participation to ensure that there is active participation from the membership and how we gather attendance rolls, things like that. We will make it as painless as possible. I will promise it would be like a one meeting, one and done. That is always my goal for a bylaws review.
No outrageous things.
So, all right. If you're interested in helping, please let us know, but I think we do need a vote. We had a first and a second. So anyone opposed to forming a work group, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right. Please reach out to either myself or Shelley if you would like to participate. We do have a couple follow-up agenda items from our last staff meeting in September. The first one was specific to e-scooters and e-bikes, and then also some age brackets for alcohol and drug use. These were 2 great requests that we had from the staff committee, and I know Vatsal and her team has been working on that. Vatsal, did you want to share the screen to go over this data?
Sure.
All right, thank you.
So this dashboard is now available on our website. It has been updated to include, this is our trauma annual report dashboard, and this dashboard has been updated to include a separate page for drug and alcohol as requested by you guys. So I'm not going to present the entire dashboard. I have presented this dashboard of trauma annual report, on the last step meeting. So we'll just look at this, the new page we added for the drug and alcohol. We have the flexibility to go till 2017. Over here for the 2024, as we know, we have total 74,000 cases, 74,297 trauma incidents. And what it tells us over here is age and gender distribution for drug if there is a suspected or confirmed use of either drug or alcohol. So age and age distribution for drug and alcohol, and similarly gender distribution for drug and alcohol over here. What we saw is that 12% of the cases had either suspected or confirmed use of alcohol and 16% drug. So the drug is more than alcohol, which the trend we have been observing since last few years, that if the drug is increasing than alcohol. The, age group wise, the drug is kind of prevalent throughout, from 18 to 24 to, we can see 75 to 84. It stays at 13% to 7% between that range, 7 to 13%. And similarly, alcohol is also like kind of in the same age group. Gender, more male compared to females, both either drug or alcohol, 70% in males in alcohol, and then almost similar 70% in drugs too. We saw the same distribution. I also did, I know we requested only age and gender, but it was interesting to see the by trauma mechanisms, like which mechanism has more drug and alcohol confirmed patients compared to other mechanisms. So what we are seeing over here is like MVT other and MVT pedestrians. They have like really high, like 51% of MVT related pedestrian injuries where the pedestrians had either the drug or alcohol suspected or confirmed use. Similarly, on the firearm injuries, we see like 56% firearm injuries, like more than half cases were either had a suspected or confirmed use of alcohol or drug. So we can just look at it like, if you put your pointer at any of the mechanism of injury and then figure it out, there are how many cases were present or what percent is there. If there is anything below 6, then we won't be able to see it. They are all just, for confidentiality purpose. We have like, you will see the asterisks over there, like over there, if the sample size is less than 6. So that, yes.
Can you maybe specify some of the changes we've seen in trends of alcohol use versus drug use in the last several years? I think you had shown kind of based on years that we've seen alcohol incidences go down and drug use go up.
Yep. Let me see which page we will be able to see that. So as a trend, let me pull up over here. 2000. Okay, let's just do here. 2017. So in 17, like we had 14% around alcohol, 13% drug. And we don't have like a graph which showing over the years, but I can add that graph also easily over here if that is something we want to do it. And then, so we just have to just see individual year over here, and slowly we see that it's kind of, see the percent is increasing. Then the drug is now increasing now in 2023, 15%, and in 2024, 16%. It's on this side box, but I can create a graph like Dr. Bradley, what you're suggesting, some similar to something like this, so we can see the trend.
Okay, thank you.
Mm-hmm.
I did think that was interesting. We have had questions over the years regarding how trends in regards to laws with first medical marijuana and then marijuana becoming legal, also the opioid epidemic. Part of the barrier is also detecting some of that data. With fentanyl use, sometimes a lot of the old drug screens weren't testing for fentanyl, so you had to test separately for that. But also that's one of the most common pain medications used pre-hospital. So if a patient gets treated with fentanyl, then the question becomes, is this a positive drug screen from opioid use disorder versus appropriate medical treatment. But I do think when you look at the trend, it's interesting to see that uptick, I think does match what we've seen with some of the drug use across the state. So I think trying to gather more of that information, and we really appreciate the trauma centers inputting that information. I think that helps paint a picture when we look at some of the prevention strategies that can be used. So thank you for adding this in, Vatsal.
Sure. And so our alcohol is like this 12.9, so 13%, and it has been in 13% range since 2017, where the drug has increased from 12 to now 16% and steadily increased over the years. For the e-bikes and scooter injuries, I didn't still have a time to include that one more page, but what we decided is that including just e-bike and scooter injuries in our overall trauma annual report, it won't be an appropriate space because we do not talk about specific injuries like that. This is an overall picture of trauma. So I will be producing a separate report, either maybe a PDF or maybe a one-page dashboard. I'm not sure, but we will present that next time then.
So sometimes as we look at gathering new data, it's difficult to kind of add it to an old report. This data, as you can see, goes back to 2017. These devices are relatively new, and data collection on that is still, I would say, much newer than that. But certainly some of the ad hoc reports that Vatsal's being able to produce allows us to still gather that data and produce that data. So that is kind of the plan, is to have a separate tab on our dashboard likely that we can present that data. So a big initiative similar to our fall dashboard that we had produced a few years ago, looking at kind of our trauma falls as well as hospital discharge database falls and producing that fall dashboard. We do have the ability to create other dashboards and collect some of this data that can be used. So we do want to focus on that as an initiative moving forward in 2026.
Right. So if you see over here, you can see the fall incidents. We see MVT related trauma. So specific injury related dashboards, we have created separate dashboards for them rather than making the part of the trauma injuries like our annual report. So similarly, we can think about off-road vehicle injuries are also there over here. So similarly, we can either think about adding another page for e-bikes or producing an ad hoc report.
Thank you. And I'm going to embarrass Vatsal and just acknowledge the fact that she was given an award this past weekend for her work on off-road vehicle data collection and injury prevention across the state. So I really wanted to acknowledge, a lot of the work that is done when we think of what do you do with data, that was something that really the data that was produced from EMS data, the state trauma advisory data, and was used for legislation to actually help injury prevention. So we really wanted to say thank you to everyone who puts that data in. It's a lot of work, but recognize Vatsal, and it was nice to see that she was recognized for her work in injury prevention across the state. So thank you, Vatsal.
Thank you, Dr. Bradley.
All right. Any further questions or comments on either of those dashboards for Vatsal? Right. Moving on, are there any agenda items that people would like for consideration for the next meeting? If you think of anything after this, please email Shelley and we can add that to the agenda. Next is call to the public. Hearing none, our upcoming events are listed on the agenda here. There's also links to some further upcoming events and CE opportunities. Our next meeting will be May 21st at 9 a.m. We will have both the in-person and virtual option, and we will be giving our trauma awards at this staff meeting in May. So we look forward to that. That's always a nice opportunity to recognize those in the trauma community that are helping to better outcomes in Arizona. And if I can get a motion to adjourn, please. All right. Thank you. All right. Have a good day, everyone.